It's with great pleasure that we introduce our next speaker, Dr. Hafeeza Tamton. Dr. Tamton is a consultant in the Department of Physical Medicine and Rehabilitation at Aster Mother Areekode, and she serves as a visiting consultant at Aster Mother Areekode. With a focus on interventional physiatry, neurorehabilitation, and pediatric rehabilitation, Dr. Tamton brings a wealth of expertise and experience to our conference. Known for her enthusiasm and dedication to the field, we are honored to have her here today to enlighten us on the topic pain mimics and red flags. Please join me in welcoming Dr. Hafeeza Tamton.
Very good morning to all. So my topic is pain mimics and red flags. Pain is a common symptom experienced by many individuals, particularly in musculoskeletal system, which amounts to 47% of the general population. Among this, 39 to 45% have long-lasting problems that require medical attention. And inadequately managed musculoskeletal pain can adversely affect the quality of life and impose significant socio-economic problems. So, multimodal analgesia and multidisciplinary approaches are fundamental elements of effective management of musculoskeletal pain. So, in non-localized cause of musculoskeletal or skeletal pain or generalized pain, the list of diagnoses is vast, starting with influenza and ending with mycetism or mushroom poisoning or ultra-rare hereditary disorders. So, most of the cases referred to other specialties might be warranted, but a basic understanding of differential diagnosis is needed. So, the objectives of my presentation are to describe some of the common musculoskeletal pain mimics in short and their classic differentiating features within the time permits, and a few rare disorders mimicking musculoskeletal pain, and a few words about red flag signs. So the systemic conditions mimicking musculoskeletal pain, there are a lot, but common conditions include hypothyroidism, vitamin D deficiency, then inflammatory conditions like rheumatoid arthritis, SLE, inflammatory myopathy, then endocrine conditions like adrenal, then metabolic conditions which are very rare but excess, so X-linked hypophosphatemia, then hypophosphatasia. Then hematology conditions include hemochromatosis, in which increased ferritin level will be seen in the synovial fluid, and this leads to chronic non-inflammatory progressive arthropathy. Then hemophilia, in this bleeding into the joint happens, so acute hemarthrosis and chronic degenerative arthropathy can occur. Then sickle cell diseases and malignant conditions include acute lymphocytic leukemia, AML. Also, myofascial pain syndrome and fibromyalgia are very common but very much neglected or ignored but needs attention. Then other conditions are chronic fatigue syndrome, psychological conditions. Also in rare genetic disorders like Wilson's disease or alkatonuria, early onset arthritis may be seen. And in sarcoidosis, rheumatologic manifestations are common. Another condition is amyloidosis, in which again musculoskeletal symptoms mimicking classic primary rheumatic diseases is seen. Then some medications which cause musculoskeletal pain are statins, bisphosphonates, aromatase inhibitors, etc. Next condition is nerve compression, which is very common. So a pinched nerve can cause symptoms that mimic musculoskeletal pain. There may be pain, numbness, tingling and weakness in any part of the body. And this picture shows ulnar nerve entrapment. So differentiating nerve compression from musculoskeletal pain requires a thorough physical examination, sometimes imaging studies like musculoskeletal ultrasound, MRI and nerve conduction studies. Another example is Baxter's nerve entrapment. So this is the entrapment of inferior calcaneal nerve. So this is a common cause, or 20% of the medial calcaneal pain is amounts to this Baxter's nerve entrapment, and it mimics plantar fasciitis. Feel this referred pain. So this is the pain that is felt in a different location from actual source of pain. So it should be considered in the differential diagnosis of musculoskeletal pain, especially in cases where the pain is not responding to typical treatments. So in this picture, the dermatomes shown here are referred from multiple internal organs. So referred back pain, upper back pain may be referred from gallstones or referred case of gallstones or pancreatitis, and also pain between your shoulder blades is also called curse sign, may be very serious due to a ruptured spleen. So lower back pain or flank pain may be referred from colon or kidney. Then referred shoulder pain. Referred shoulder pain may be originating from lungs, liver, heart or gallbladder. Then referred arm pain can happen in angina or cervical disc disease, and also in trigeminal neuralgia there will be referred teeth and jaw pain. Also in angina, referred jaw pain is seen sometimes. So what is an autoimmune disease that causes chronic inflammation of the joints leading to pain, swelling and stiffness? Yes, it is rheumatoid arthritis, and there is a diagnostic criteria 2010 ACR and Euler criteria in which joint distribution, serology, symptom duration and acute phase reactants are taken into account for the diagnosis. But if it is not diagnosed properly or treated in time, the chance of deformities in hands and other areas may happen. So blood tests and imaging studies are often necessary to confirm the diagnosis. 3/4 of the patients are positive for serology, anti-CCP antibody and immunoglobulin M rheumatoid factor at the serology, and these are relatively specific. So coming to radiological findings of rheumatoid arthritis, that shows swelling, joint space narrowing, bony erosions, periarticular osteopenia, then joints subluxation, etc. Ultrasound is a highly sensitive tool for early detection of erosions, subclinical synovitis and tenosynovitis in rheumatoid arthritis. So myositis is another condition. So it's a muscle inflammation and it causes pain and weakness. There may be symptoms and signs of inflammatory arthritis, fatigue, nail bed or cuticle inflammation, then skin rashes, interstitial lung disease, and also a characteristic appearance of hands called mechanics hands, in which the fingers will be crackled and like in this picture. So investigations include blood test in which elevated muscle enzymes will be seen, CPK, then MRI or ultrasound, EMG and nerve conduction studies, biopsies of the muscle and skin. Then another condition which mimics back pain is infectious spondylitis, which is infection of the spine. It's a rare but serious cause of back pain, and there will be associated features like fever, back pain, evidence of nerve compression, radiculopathy, etc. Then two adjacent vertebral bodies in the intervening disc space are affected. So early in the course of the disease, the X-ray may be normal, so we will have to go for MRI and radionuclide bond scan. Next condition is complex regional pain syndrome. So the CRPS is considered to be caused by so many factors. So the pathophysiology include, initially there will be an insult like a trauma, surgery or stroke, etc. So it causes classic inflammation, then neurogenic inflammation, autonomic dysfunction, all these contribute together for CRPS. And doubtful theories are CNS plasticity and psychological factors. So according to Budapest diagnostic criteria, it considers a few symptoms and signs, which includes sensory symptoms like hyperalgesia, allodynia, vasomotor symptoms like temperature changes, skin color changes, pseudomotor changes like edema, and motor or trophic changes like weakness and tremor. Signs also include similar ones, and also these symptoms and signs, there should be continuous pain disproportionate to the inciting event. Also the absence of another diagnosis that would explain the symptoms and signs. So there are type 1 and type 2 CRPS. Type 2 attributes to direct nerve injury. Then the diagnosis is purely clinical, as I already told you, and the management includes medications which include bisphosphonates, glucocorticoids, calcitonin and vasodilators, also together with some neurotropic medications. Then other than medications, there are graded motor imagery like mirror therapy. Then RM exercises, range of motion exercises are very important. Then physiatrists do sympathetic blockade like stellate ganglion block or even suprascapular nerve block with the peripheral nerve block with a very high success rate. So Diabetes is very common, so musculoskeletal conditions predisposed by diabetes is very common. So I am not going to details of all the conditions, but some conditions which need are there is diabetic amyotrophy, and then comes the diabetic muscle ischemia, which is a very painful condition. There will be a painful palpable mass. It is said to be caused by microangiopathy in diabetes, and the diagnosis is by MRI. Other condition is infectious myositis or pyomyositis, in which associated features like fever, leukocytosis, elevated inflammatory markers happens, and MRI is diagnostic, and bacteremia also will be there. MRI diagnose the case, so the management include antibiotic therapy and abscess drainage. So in this picture, this is an MRI of diabetic muscle ischemia, which shows a serpentine pattern, whereas in the second picture, this is the infectious myositis or pyomyositis. You can see the fluid inside the abscess. So another condition is inflammatory myositis, in which dermatomyositis, polymyositis and inclusion body myositis are seen. So there will be gradually progressive proximal muscle weakness in this condition. So sometimes we are confused whether the pain is psychological or musculoskeletal. So psychological conditions presenting as musculoskeletal pain are very confusing, but it's common. So conditions like stress, anxiety and depression can exacerbate musculoskeletal pain and make it more challenging to manage. So chronic pain conditions like fibromyalgia, chronic myofascial pain syndrome, and all these conditions are often associated with psychological distress, leading to a complex interplay between the physical and emotional symptoms. So psychotherapy and relaxation techniques can help improve pain management in these cases. So a few words about fibromyalgia. It's a disorder characterized by widespread musculoskeletal pain, fatigue and tenderness in specific areas of the body. So the diagnosis is challenging. It has a characteristic clinical presentation. The patient typically being a woman 30 to 60 years of age with diffuse somatic pain, with history of sleep disturbance, maybe there is associated depression, and the characteristic tender points will be there. So laboratory findings are normal, and the condition called fibrophobe may be associated with as a complication in which cognitive issues and lasting memory problems may be seen. So there is American College of Rheumatology preliminary diagnostic criteria for fibromyalgia and measurement of symptom severity, in which widespread pain index and symptom severity score is considered. I am not going into details of the fibromyalgia management. Only thing is reassurance is important. So reassurance is not like you don't have any issue. You assure the patient that you have a condition called fibromyalgia and that exists. So another condition is multiple sclerosis. It's a chronic neurological condition that can cause intermittent pain, weakness and numbness in various parts of the body. The classic symptoms of waxing and waning will be there. So a thorough neurological examination is important. MRI of spine and brain, there will be evidence of demyelination, patchy, fluffy lesions will be there. Then evoked potentials are done for problems with eyes, to rule out optic neuritis. Then CSF study yields immune cells and antibodies. Then blood should be done to rule out, to find antibodies for neuromyelitis optica, which is a similar diagnosis. So coming to chronic fatigue syndrome. I am rushing through the slides because of the time constraint. So it's a complex disorder, also known as myalgic encephalomyelitis. So there will be classic overwhelming fatigue that is not improved with rest, associated with muscle pain, headache and cognitive difficulties. Duration will be more than 6 months usually. So the diagnosis is purely clinical, and there is 2015 Institution of Medicine diagnostic criteria for CFS for diagnosis. Then management includes cognitive behavioral therapy, graded exercise therapy and specialist medical care together with medications which includes antidepressants. So Lyme's disease is a rare condition. So it's a bacterial infection transmitted through tick bites that can cause joint pain, muscle aches and neurological symptoms. So, but the serious manifestations are cardiac manifestations, which are syncope, shortness of breath, palpitations, chest pain and AV conduction block. So it is caused by a tick called Borrelia burgdorferi. It is shown in here, and a characteristic bullseye shaped skin rash will be seen. So diagnosis is by testing Lyme antibody test and then culture of Borrelia from skin, blood or CSF, and detection of genetic material by PCR method in skin, blood, synovial fluid and CSF. Another issue is sickle cell crisis happens in sickle cell anemia, in which the RBCs RBCs become crescent or sickle shaped due to genetic mutation. So they get stuck in the blood vessel and occluded blood flow into an area happens, and that causes pain in the chest, arms and legs. In infants and young children, there will be painful swelling of the fingers and toes. So routine laboratory examinations of the CBC, differential count, reticulocyte count, and a complete metabolic panel including liver function test is important. So management of the pain includes analgesics like morphine, and you should avoid icing. So rare conditions like some case reports. In one cases, an adult wheelchair basketball player having osteoblastoma presenting as shoulder pain. Then another rare condition was in a patient with 65-year-old, about 30 years of diagnosis with ankylosing spondylitis, and he was on DMRs. He had undergone surgery for ankle enthesitis and arthroplasty, but not diagnosed the X-linked hypophosphatemia as a real diagnosis later on. Then another condition, hypophosphatasia, mimicking as osteoarthritis knee. Then coming to a few words about only one or two slides about red flag signs and its features. Red flag signs are features from a patient's subjective and objective assessment which are thought to put them at high risk of serious pathology and warrant referral or further diagnostic testing. Mentioning the symptoms: night pain, systemic illness, constitutional symptoms like fever, weight loss, numbness and tingling, severe disability, swelling with no injury and multiple joint injury or pain. All these are the musculoskeletal red flags. So these red flags given in this table are for spine. So main concerns are fracture, tumor or infection, or Kodai-Kinner syndrome. So fracture is suspected in case of major trauma or minor trauma in elderly or with those with osteopenia. Tumor or infection is considered over age of 50 or under age 20. Then constitutional symptoms like fever, chills or unexplained weight loss. Also history of UTI, drug abuse, IV drug abuse or immune suppression, and pain was at night. Then Kodai-Kinner syndrome, like we know, saddle anesthesia, bladder symptoms or severe and progressive lower extremity weak neurological deficits. So international framework for red flags for potential serious spinal pathology help for decision tool for early identification of potential serious spinal pathology. So a person is referred with musculoskeletal condition. If there are no concerning features, you can treat as planned and monitor symptoms and progress as if it is progressing as expected, treatment proceeds as expected. Whereas if the patient is not improving or new concerning features happens, you can directly send the patient to consider further investigations or for referral. In that case, if the patient is having few concerning features at presentation, consider watchful wait. Also initiate treatment, wait. If it is progressing well, again go to the green zone. Otherwise, send the patient to red zone. That is consider further treatment, investigations or referral. Again, the patient is coming with some concerning features, actually go to the red zone. That is send the patient for further investigations and refer the patient. That's all. Thank you.